These are two novel indices to physiologically assess the coronary stenosis severity. QFR is an angiography-based index that is calculated based on two coronary angiograms that are taken on two orthogonal views. Very simple to acquire. It takes some post-processing done by the operator, but it gives you reliable information about the functional significance of the coronary stenosis. OFR is calculated based on an OCT imaging acquisition. So it's an OCT-based physiologic index. And is also providing you with functional information about coronary stenosis severity. The unmet clinical need here is that there has been an attempt to overcome the limitations of pressure wire-based coronary physiology that are related to the manipulation of the pressure wire, to the need of using a vasodilator, and to the costs related to the equipment needed to do this kind of physiology. Now, these two indices have proven to be good enough to estimate what is the functional significance of the lesion and nicely compare in terms of diagnostic accuracy with FFR. So they are both in a phase of clinical validations. QFR is being already studied in different trials, and now we are having randomized clinical trials that are really providing to the community the true clinical benefit of implementing this methodology by comparing QFR-guided revascularization as compared to angio-guided revascularization. OCT is more into an early stage, the OFR index, and needs more clinical validation. I can answer you very bluntly by saying that you would use QFR when you want to decide whether to treat or not to treat. You could use OFR once you decided more or less that you want to treat, but you want to have confirmation of your decision. And most of all, you want to assess how good it was the functional result of your revascularization. We have clinical data available for QFR. As I said before, we are in the stage of obtaining randomized data where we have head-to-head comparison with classic angiography-guided revascularization. We don't have yet, for the time being, clinical validation, extensive clinical validation for OFR. For the time being, I've gathered some experience with QFR, and it turns to me to be a useful tool, especially in the context of patients with multivessel disease, in acute coronary syndromes where I don't want to put at risk the non-culprit vessel after having revascularized the culprit lesion in the context of a STEMI patient.